Good afternoon, everybody. I'm Sarah Rosenbaum, the chair for the IOM committee responsible for this report. I'd like to thank you for joining us for this report release webinar. We are going to spend about a half hour describing the findings, and then we will open it up for questions and general give and take. The report is Speech and Language Disorders in Children, and on behalf of the committee, I'd like to thank the Social Security Administration for funding this study, and I am joined this afternoon by my fellow committee members, Bill Barbaresi, Susan Parrish, and Bruce Tomlin. We're looking forward to discussing the report with you and answering any questions that you might have. And I'm going to turn things over to Bruce Tomlin to provide some background for the study before we get into the report and its overall conclusions.
Okay, thank you, Sarah. Given the committee's task and the general level of familiarity with speech and language disorders, particularly those that are severe and disabling in nature, we thought it would be helpful to begin with some definitions and background information. As this slide notes, speech is the production or pronunciation of meaningful sounds resulting from the complex coordinated movements of the oral mechanism, that is the mouth and the related structures. Speech disorders are deficits that may cause speech to sound abnormal or prevent it altogether. Language is the code or system of symbols for representing ideas in various modalities, including understanding, that is comprehending, and speaking, reading, and writing. Language disorders are conditions that interfere with the ability to understand the code, to produce the code, or both. We can go on with this. Speech and language disorders in children are disruptions in communication development. They are usually identified when a child does not achieve expected or normative developmental milestones. In their most severe forms, like those that children in the SSI program often experience, speech and language disorders can be expected to persist over a lifetime. As this slide illustrates, the functional requirements for language and communication increase continually throughout childhood. For children with moderate to severe speech and language disorders, these requirements often outpace their development. Thus, even if children with such disorders make some progress from growth and with treatment, the gap between their abilities and functional expectations widens. Research shows that severe speech and language disorders can increase risk for a wide variety of adverse outcomes, including social isolation and mental health disorders, learning disabilities, behavior disorders, poor academic achievement, and chronic underemployment. These outcomes point to the array of needs children with severe speech and language disorders are likely to have, and to the kinds of ongoing support they may require. The Supplemental Security Income program for children provides financial assistance to children from low-income, resource-limited families who have been determined to have conditions that meet the disability standard required under law. When sufficiently severe, speech and language disorders can qualify children for SSI disability assistance. Over the past several decades, the number of children receiving SSI has risen overall, and the number receiving SSI on the basis of speech and language disorders has also risen. In December 2014, 213,688 children were receiving benefits as the result of a primary speech and language impairment, 16% of all children receiving SSI benefits. The Social Security Administration determined that additional research was needed to understand the increases in the number of children applying for and receiving SSI benefits on the basis of speech and language disorders. In 2014, the Social Security Administration's Office of Disability Policy requested that the Institute of Medicine convene a consensus committee to 1, identify past and current trends in the prevalence and persistence of speech-language disorders among the general U.S. population, under age 18, and to compare those trends to the trends with the SSI childhood disability population. And 2, provide an overview of the concurrent status of the diagnosis and treatment of speech-language disorders and the level of impairment due to these disorders in the U.S. population under age 18. In addition, the committee was asked to identify and describe causes, consequences, and frequency of speech-language disorders in children, the average age of onset and levels of impairment, and how age, development, and gender factor into the progression, common comorbidities, and professionally accepted standards of care. The report, Speech and Language Disorders in Children, Implications for the Social Security Administration's Supplemental Security Income Program, is the culmination of the committee's review. I'll now turn things over to my colleague, Susan Parrish, to introduce the committee's overall conclusions.
Thank you so much, Bruce. The committee reviewed a range of sources to respond to its charge, including published research on the etiology, epidemiology, and treatment of childhood speech and language disorders, expert testimony, data from clinical studies, data from nationally representative surveys, and data from federal programs. Based on its review, the committee arrived at 7 overall conclusions in 5 key areas. The 5 key areas were listed on the slide. 1, the impact of severe speech and language disorders. 2, prevalence and comorbidity. 3, supplemental security income. 4, assessment, evaluation, and standards of care. And finally, trends in the general population compared with trends in the SSI program. The committee's first overall conclusion is that severe speech and language disorders in children are conditions that interfere with communication and learning and represent serious lifelong threats to social, emotional, educational, and employment outcomes. This conclusion underscores the significance of severe speech and language disorders in children, as these conditions are sometimes misunderstood and mischaracterized as minor impairments with few long-term consequences. In fact, these disorders, which affect a small percentage of children, can markedly limit a child's functional ability and have lasting consequences. Deficits in speech and language can range from mild to severe. In clinical practice, scores that fall more than 2 but less than 3 standard deviations below the mean are described as severely or extremely low. Only 2.14% of children would be expected to score so poorly. Scores that fall 3 or more standard deviations below the mean are extraordinarily low. Only 0.13% of children would be expected to score this poorly. This figure on the slide shows that only 1 child in 1,000 would be expected to score 3 or more standard deviations below the mean, and only about 22 children in 1,000 would score more than 2 but less than 3 standard deviations below the mean. The committee's next overall conclusion is that speech and language disorders affect between 3 and 16% of U.S. children, and approximately 40% of children with speech and language disorders in nationally representative studies have serious comorbidities, such as intellectual disabilities, autism spectrum disorders, and other neurodevelopmental and behavioral disorders. Excuse me. This table that you're seeing on this slide provides a summary of prevalence estimates from the studies of U.S. children that the committee reviewed. This list is not the result of a meta-analysis, nor is it exhaustive. Rather, this table includes a number of well-designed studies that employed clear and consistent definitions. It also includes the estimates of prevalence from several national surveys. The report provides more detailed information on how these studies and surveys vary in terms of ages, diagnostic tools or criteria, and methods used, and how such methodological variation affects the estimates. Collectively, The estimates from these studies and surveys show that speech and language disorders affect between 3 and 16% of U.S. children. Finally, data from the 2000 to 2012 National Health Interview Survey indicate that more than 40% of children with speech and language disorders experience comorbidities such as developmental delay, autism, or intellectual disability. And the recent National Health Interview Survey Voice, Speech, and Language Supplement indicated that intellectual disability is the most common comorbidity, representing 52% of all comorbidities, followed by developmental delay, seizures, and attention deficit hyperactivity disorder. The committee's next overall conclusion is that children of families with low incomes are more likely than the general population to have disabilities, including speech and language disorders. The Supplemental Security Income, or SSI program, is designed to award benefits to the most severely impaired children from low-income, resource-limited families. Currently, 0.31% of U.S. children receive Supplemental Security Income benefits for speech and language disorders. The next few slides elaborate on this conclusion. The SSI program for children was established to address the needs of children with disabilities living in low-income households because they were determined to be, quote, among the most disadvantaged of all Americans and are deserving of special assistance, unquote. SSI recipients include children whose health conditions or disabilities are severe enough to meet the program's disability eligibility criteria and whose family income and assets are within the limits that are specified by the Social Security Administration. As you can see from this slide, the number of children who receive SSI benefits is based on a primary speech and language impairment, meaning children whose disorders are severe enough to meet SSI medical eligibility criteria and whose families meet the financial eligibility criteria, is a very small subpopulation of children in the general U.S. population. These are children whose disabilities are severe, at least 2 to 3 standard deviations from what is considered normal functional ability for their same-age peers. And these conditions are expected to persist over time. Children living in poverty are at greater risk for a disability relative to those children who are not living in poverty. And childhood disability increases the risk that a family will live in poverty. Moreover, childhood poverty can exacerbate disabilities and their effects and lead to poor outcomes across a range of indicators, including emotional, social, and mental development, academic achievement, and employment during later adulthood. The converse is true as well. The consequences of poverty are likely to be especially serious for children with disabilities because of their heightened vulnerabilities, their elevated needs for health care, and their overall poor health. Data from the SIP, the Survey of Income and Program Participation, indicate that children with speech and language disorders are more likely than other children to live in poor or low-income households. 26% of children aged 16 to 17 with speech and language disorders lived in households where family income was below 100% of the federal poverty level. This is contrasted with the 21% of children without speech and language disorders and 28% of children aged 6 to 17 with speech and language disorders living in households that were considered near poor or with income below 1 and 2 times the federal poverty level, versus 23% of children without speech and language disorders. Our committee was asked to identify accepted standards of care and to identify the kinds of care documented or reported to be received by children who received SSI for speech and language disorders. Chapters 2 and 3 of our report discuss standards of care at length. In addition, the committee reviewed a random sample of case files to learn about the types of evidence that were used to determine eligibility for SSI, as well as the characteristics of children who are allowed eligibility on the basis of speech and language disorders. Our committee concluded that to determine the severity of speech and language disorders in children, the Social Security Administration employs the results of professionally administered assessments, and also takes into account other clinical evidence that would be consistent with severe speech and language disorders. This evidence includes standardized testing, diagnostic evidence derived from non-standardized ratings and measurements, and developmental screening reports. And it's important for me to note that parental or caregiver reports and observations alone are an insufficient basis for a finding of disability by the Social Security Administration. Now let me turn things over to Bill Barbaresi, who will discuss the committee's conclusions related to trends in speech and language disorders in children.
Thanks, Susan. Before I talk about the committee's overall conclusions regarding trends, I thought it would be helpful to describe the sources of data that the committee reviewed and also some important limitations that these data presented. First, it's important to emphasize that there's no single data set, or really even a small set of data sources, that can provide definitive population estimates of the prevalence of speech and language disorders over time among U.S. children. As a result, the committee consulted a variety of data sources to identify trends in the prevalence and persistence of speech and language disorders, including data from clinical samples, population-based studies, nationally representative surveys, and administrative or service-based data from federal programs. These sources, of course, differ substantially with respect to how they define or designate speech and language disorders in children, how they collect information. For example, some involve parental reporting, some involve medical records or test records, which variables are examined. For example, the level of severity or duration of the disorders, child or family demographic information, etc., and also the period of time examined, among other factors. Understanding these limitations, the committee concluded that the best available evidence shows an increase in the prevalence of speech and language disorders over the past decade in the general U.S. child population. Trends in annual supplemental security income allowances parallel this overall increase in the general population. In order to derive estimates of trends in prevalence in the general U.S. population, the committee used weighted percentages from two national surveys, the National Survey of Children's Health and the National Survey of Children with Special Health Care Needs. As you can see on this slide, the proportion of children with speech and language disorders in the general U.S. population based on the 2005, 2006, and the 2009-2010 National Survey of Children with Special Health Care Needs. Here, we see an estimated 56% increase in prevalence from 3.2 to 5.0% between those two time periods. The second slide shows the proportion of children with speech and language disorders, again in the general U.S. population, based on the 2007 and 2011 National Survey of Children's Health. And here we see an estimated 26% increase from 2007 to 2011, going from 3.8 to 4.8%. Finally, this slide shows trends in initial allowances for speech and language impairment as a primary condition from the fiscal years 2004 to 2014. And as you can see, the number of children who met the eligibility criteria for SSI in each year for a marked or extreme speech or language impairment increased by 24% between 2004 and 2014. The figure also shows increases in allowances within the SSI program during years that correspond to the years of administration of those two surveys we just reviewed in the prior slides, the National Survey of Children with Special Health Care Needs and the National Survey of Children's Health. Here, we see a 27% increase in SSI allowances for speech and language impairments between 2005 and 2009, which is markedly lower than the 56% increase in prevalence of these same disorders reported by the National Survey of Children with Special Health Care Needs for the same period of time. On the other hand, we see a 40% increase in SSI allowances between 2007 and 2011, which is larger than the 26% increase in prevalence reported by the National Survey of Children's Health for, again, the same period of time. While the percentage increases do not match up precisely, the committee concluded that the trends in annual supplemental security income allowances parallel the overall increase in the prevalence of speech and language disorders over the past decade in the U.S. child population. This next slide includes the committee's overall conclusion regarding the persistence of speech and language disorders in children. Children with mild to moderate speech and language disorders will benefit from a variety of treatments. For children with severe speech and language disorders, treatment improves function. However, with few exceptions, these children will continue to have substantial functional limitations. This conclusion is especially relevant to the SSI program for a number of reasons. First, children with severe speech and language disorders are most likely to meet the medical eligibility criteria for SSI for primary speech and language impairment. And second, research has shown that these severe conditions are likely to persist and inhibit function throughout childhood, even with treatment and intervention. Finally, the persistence of these disorders has an impact on the number of children who will remain medically eligible for SSI benefits. Which brings us to the committee's final overall conclusion, that the number of children receiving SSI for speech and language disorders can be explained by an increase in the prevalence of these disorders in the general population, by the introduction of a new impairment code for speech and language disorders in 1994, and by the continuing eligibility of children whose severe speech and language disorders persist throughout childhood. This slide illustrates the growth in recipients following the addition of the impairment code for speech and language disorders in 1994. Prior to 1994, there were 0 initial allowances for the impairment code for speech and language disorders in children. The current total number of recipients reflects both the accumulation over time of new individuals in this impairment category and, importantly, the very low attrition rate from the program due to the persistence of severe speech and language disorders. As a result, the total number of children receiving benefits for this impairment code in a particular year approaches the total number of children allowed benefits in each of the preceding 18 years. For example, the total number of recipients in 2014 likely includes nearly all of the children allowed benefits within the 18-year period from 1997 to 2014.
Thank you, Bill. So taken together, the committee's report helps characterize the current state of knowledge regarding trends in speech and language disorders in children in the general population and among SSI program participants, and points to deficiencies in evidence related to both populations. The report's findings and conclusions are important for a number of reasons. First, our findings underscore the long-term and profound impact that severe speech and language disorders have on children and their families. These are very serious conditions. They are severe enough to meet the rigorous eligibility criteria of the SSI program, and they can be expected to persist through childhood. Second, understanding the nature of these conditions and the SSI determination process, particularly the introduction of a new Speech and Language Disorders Impairment Code in 1994 helps explain the degree to which children with these disorders can be expected to be a significant presence in the SSI program, how children with these conditions have accumulated in the program over time, and why there has been a significant increase in the number of children with speech and language disorders in the SSI program. Finally, when it was enacted into law in 1972, the SSI program for children was established to address the needs of children with disabilities living in low-income households because they were determined to be among the most disadvantaged of all Americans and are deserving of special assistance. The committee's report shines a light on how the SSI program design and the SSI program processes operate together to connect the nation's most severely impaired and disadvantaged children to the benefits that the program offers. Thank you very much for joining us today. We look forward to answering questions you might have. Please feel free to send questions in. And I'm going to kick us off, actually, with a couple of questions about the report. So, Bill, let me start with you. How do the findings in this report, in our report, correspond with the recent report on SSI for children with mental disorders? Would you say the conclusions were the same, different? Discuss that a little bit.
Sure. Well, first, it's important to emphasize that these two reports were generated by two different committees working entirely independently. So we did not have any information about the content or the findings of the mental health disorders report prior to its release, which was after we had completed work on our report. And second, it's important to emphasize that, of course, we're studying two very different things, ours being on speech and language disorders and the other report being on mental health disorders. Having said that, there are some parallels in that both reports found a general increase in the rate at which these disorders are occurring in the general population, and some parallels between that general increase in the rate of these conditions and rates that have increased at the same time in the SSI population.
Thank you. Bruce, can you elaborate a little bit on what the report does and does not address around treatments for children with speech and language disorders? Did we identify effective treatments? Talk a little bit about our treatment findings.
Okay, thank you. Our main focus here was to examine the treatments that are most likely to be provided, particularly to this population and this age group, and to address issues having to do with the degree to which these treatments were, one, efficacious, but in particular, the extent to which one could expect that these treatments would resolve the problem and therefore lead these children to no longer present any need for additional support. And so I think what we primarily focused on, therefore, were describing the more common kinds of intervention methods that were used and the degree to which those could be expected to particularly resolve the problem. And our conclusion there was that, particularly for this population, it was unlikely that very many children would be, in effect, cured of a communication problem, but rather that the interventions were going to provide improvement in function, but that the child would have ongoing needs.
Thank you very much. Susan, a couple of questions for you. One is, what can we say at the end of this report about the factors that might be causing the increase in the prevalence of speech and language disorders in the general population? And as a follow-up, how do children with speech and language disorders in the general population differ from children with speech and language disorders who receive SSI benefits?
Sure. Thank you, Sarah. I think before I answer these questions, I would like to direct our audience to chapters 4 and 5 of the report, which provides a much more thorough answer to these questions. With regard to your first question about trends in speech and language disorders in the general population of U.S. children, you know, the evidence is actually quite thin, and our committee raised some concerns about our ability to make definitive conclusions or to draw definitive conclusions about the factors that are contributing to the increase in the prevalence of these conditions among the general population. Certainly, we believe that increases in poverty are associated with increases in the likelihood of a child having speech and language disorders. We also feel that clinical research advances, which have focused on identifying markers and indicators of these disorders in younger and increasingly younger children, has also increased our prevalence estimates. But it's very clear to this committee that further research is needed to help us understand the drivers of these prevalence trends. With regard to differences between the general population of U.S. children and the population of children who are receiving SSI benefits for speech and language disorders, there are a couple of extremely important differences. The first, of course, is that the Social Security Administration's very strict rules about family income and assets, or their wealth holdings or their resources, means that the population that receives SSI is much poorer than the general population of U.S. children, and so that's the first difference. The second difference is that in order to qualify for SSI on the basis of a speech and language disorder, children have to have scores that are below 2 standard deviations from the mean, and as we mentioned, these are children whose conditions are extremely severe, much more severe than the overall trend of speech and language disorders general population of U.S. children.
Thank you. Let me just encourage people who might have questions to send them in to us. Susan, one more follow-up question. Can you talk a little bit about the report's examination of what role, if any, is played by either race or ethnicity or gender in childhood speech and language disorders?
Oh, certainly. The evidence base on the effects of gender is very limited, and our committee did not really find research that was examining either the differential effects of treatment on boys or girls or real differences in prevalence. So further research is needed to understand that. And the situation is largely similar for children from different racial and ethnic identities. When we analyzed data and looked at the large national surveys, we did find slight differences in the prevalence of speech and language disorders by race and ethnicity. However, upon closer examination, these differences were not statistically significant.
Thank you. Bill, let me ask you a question. How might healthcare professionals or professional organizations use the information that we've included in this report?
Sure. Well, first of all, we were not asked to make explicit recommendations to the Social Security Administration, aside from addressing the questions that were included in the Statement of Task. But the committee, based on having spent months together examining the available literature on this topic, and in particular, as Susan was just pointing out, on the epidemiologic data available, reached the important conclusion that we need more research. And in particular, we really need more research on the epidemiology of speech and language disorders, including primary speech and language disorders, so that we can really understand more precisely the incidence and prevalence of the conditions, their natural history, their outcomes, how they vary by race and ethnicity, and by socioeconomic status, among other important issues, very much in the way that similar research has been conducted in areas like ADHD and autism.
So large-scale studies.
Large-scale epidemiologic studies that are representative.
So really the major contribution of the report, in addition to the specific findings, is to underscore the need for a new generation of research around these particular disorders in children.
Absolutely.
Bruce, I wonder, just to sort of make this report even more real for people, one of our important findings has to do with the fact that here we are talking about not children with mild to moderate disabilities or disorders, but very severe disorders. And I wonder, for our listeners, if you might offer people a couple of examples of the kind of disability or disorders we're talking about, and Bill, feel free to chime in as well from your own experience.
Okay, yes. It is a little bit difficult sometimes to get some sort of concrete sense of what kinds of communication skills children with these levels of severity may have, and there are multiple dimensions with regard to their communication skills, particularly having to do with speech and language. But just to think about this, we could maybe envision a child who's 4 years old in sort of the heart of the preschool years, who is at this point in time functioning with the communication skills, both speech and language, of a child that's around 2 years of age. And so you can think of what a 2-year-old would be able to do, a normal 2-year-old, and that child is able to put a few words together, make some simple sentences, although we wouldn't view them as complete. They're not adult-like. Those sentences can function to get certain needs met, to express different simple ideas, but they're going to be pretty simple ideas, and seek out information to some degree. The child's vocabulary is going to be quite limited to maybe a few hundred words or so, but substantially less than what we would expect in a 4-year-old. The child's intelligibility, how we can understand the words that are being pronounced, would be quite as well. Immature, you could understand the child in context perhaps most of the time, but in some settings and to some listeners, the child may be hard to even understand. Now, the 4-year-old, in contrast, what we would be expecting of that child is that child could engage in conversations, answer questions, ask questions, and in fact, really, in many cases, put a number of ideas together into a complex of several sentences explaining something and so forth, and those would be far beyond what a 2-year-old would be able to do. A 4-year-old we expect to be pretty intelligible. Most of the time we'd be able to understand what that child is saying. And all along, the 4-year-old would be able to understand a great deal of what we might be saying to them, even if it's generally somewhat sophisticated, but the 2-year-old we would have to really simplify the way we're going to be talking. That same kind of discrepancy could extend on into the school years, where you could have an 8-year-old in the classroom functioning like again, a 4-year-old or so. And if you think of a 4-year-old in a second-grade classroom, that child is going to have a considerable difficulty with almost all the academic material. What the teacher is saying, developing all the reading skills and the writing skills. So these are children who are not limited with regard to their communication skills just on the edges, but in fact have fundamental core difficulties with meeting a range of communication functional skills. I don't know, Bill, do you have any?
No, that's a very thorough description that clearly indicates that you're a speech and language expert as opposed to me as a developmental pediatrician. But, you know, from the perspective of a more developmental generalist, if you will, to me, when I think of a child in my clinical practice who's functioning 3 standard deviations below the mean, for example, on a measure of communication skills, in a general way, that means a child who, if they're younger, may be virtually unable to communicate, except with specialized supports that can help to a degree to circumvent the really severe impairment, to a school age or older child whose communication is extremely limited and, again, typically would require supports like visual aids and, you know, if it's a speech production issue, something like an electronic device that can assist with communication. So that's just my sort of more general perspective on it.
Thank you, Bill. So we have a question from one of the listeners. Given methodological differences described, would it be beneficial to explore a change in wording of the questions that assess these disorders in the National Health Interview Survey, or maintain the current wording to measure trends with the new survey? So just to underscore, we were not asked to comment on or suggest approaches to doing a better job of gathering evidence about the existence of these disorders in children, or how to formulate survey questions that would more accurately produce such evidence. And while, as Bill noted, we absolutely recommend the need for better large-scale studies, we were not asked to comment specifically on the kinds of question changes that might be needed in the existing studies, or to recommend the alignment of various evidence sources going forward. Let me throw out another question. Bill, among the children who receive SSI for speech and language disorders, what do we know about the other conditions they have? We certainly report on the proportion of children who have other conditions. I wonder if you could elaborate a little bit on this part of our study.
Sure. I wonder if I could go back just for 1 second to the last question, though.
Of course. Of course.
And just to add that we did encounter the issue of varying ways in which questions were asked in different surveys, and in some cases, as Susan knows, since she's really an expert in these national data sets, in some cases the way that a question was asked in the same survey at different points in time. So while recommending a specific approach for a national survey, as you pointed out, Sarah, goes beyond the scope of our report, we did encounter the challenges that result from having those questions asked in different ways at different points in time and in different ways in different surveys.
Absolutely, and I think there's a lot to learn just from that finding that we made, even if we did make recommendations for straightening out the problem.
Exactly. With regard to the question of conditions that are associated with speech and language disorders, or the term that we use is comorbidities, as I think was pointed out on one of the slides, in one of the available data sets, 40% of children with a speech and language disorder had at least one associated other developmental disorder, and among the more common ones are things like general developmental delays in younger children, or intellectual disability in school age and older children, as well as things like ADHD and autism. And this is not surprising. in that it's consistent with what we know about neurodevelopmental disorders in general, which is that they tend to overlap considerably in each child affected by a specific disorder.
Great, thank you very much. I'd like to sort of add an observation of my own. We've talked a lot about the major findings and conclusions that we offer in this report. And this report, of course, is not a report about SSI policy per se. We were asked to talk about why children with serious speech and language disorders are present in the program and a growing presence in the program. I think at one level it's important to note that while, of course, this report is about speech and language disorders in children, it's a report that also sheds a little bit of light on what factors cause a public program like this to grow. You know, why did we go from this not being a distinct issue for the SSI program to one with a couple 100,000 children enrolled in the program? And really what we find in this report is sort of a threefold phenomenon. One is just that things change in the general population, and as life changes in the general population and certain conditions increase in prevalence, they're inevitably going to have some spillover effects onto a population that is at risk, of course, for having a more significant, for experiencing a more significant effect from adverse conditions because of poverty. So I think there's the general prevalence issue. And then there's the second key finding is that the way a program is administered may have a role, and here, of course, specifically the issue is the creation of a discrete and identifiable code designed to better capture a serious disability in children that previously had been buried, had not been accurately collected or understood as a condition that can cause a disability in a child quite apart from the presence of other conditions. So that's a second factor, the advent of the code. And the third factor, which is, of course, would be a factor in a program like SSI, which is designed to address the needs of people with the most severe disabilities in society. Here, what we're dealing with is persistence. So as Bruce discussed, there are treatments that can that are effective, that can mitigate the impact of a very severe disability in a child, but by and large, they can't cure disability in children, and the disabilities can be expected to remain quite severe, and children can be expected to remain in a program. So our findings obviously go to the question of speech and language disorders in children, and they help, you know, in this case, they help the Social Security Administration understand why their own program for these particular children changed over time. I think that concludes our webinar. I want to thank my colleagues. This was a particularly wonderful study group, and I learned an enormous amount from being able to participate in the study group with Bill and Susan and Bruce and the rest of the committee members, and we hope that you find the report useful.